Welcome, everyone. This is Gynocurious, and I'm your host and creator, Dr. Amy Novat. We are here to investigate what it means to be a healer and to be healed. Please send your comments or thoughts to radiofreerhinecliff.org or gynocurious@gmail.com. We'd love to hear from you. Please consider giving us 5 stars on whatever platform you listen and share the show with your friends. So today I am excited to have another conversation about the body and the mind. For decades in the world of allopathic medicine, there was a divide, a schism between the illness of the body and the illness of the mind. Only more recently in the history of allopathy have we realized there's an absolute connection between the emotional plane and our physical symptoms. Together they work in concert both in pathology as well as in healing. My guest today, Alyssa Padial, a physical therapist for over 2 decades, is here to speak about how she takes care of women, understanding the critical importance of setting achievable results and finding health through confidence and knowing the body, addressing the remarkable mingling of the mind and the body. Alyssa worked at a New York Presbyterian in New York City for 27 years as a PT, and then left to establish her own practice several years ago to allow her a greater breadth in healing with creativity and treatment options. She is double boarded in orthopedics and pelvic rehabilitation, a certified Pilates instructor, and a semi-professional dancer, which I can't wait to talk about. Welcome, Alyssa.
Thank you so much. It's so wonderful to be here and in your little nook in Rhinecliff, New York, and really honored to be here with you. Thank you for having me.
Yeah, we love our nook. It's right here on the Epicurean, and a store that we love to promote and express our appreciation for because they have been just so kind towards keeping us here at Radio Free Rhinecliff. So, you know, when we were talking about your coming on the show, you told me that you recently led a group of women in a discussion with the theme of hope, or health, optimization, and personal empowerment in knowing your body. Can we start with that theme? Can you unpack that for us, please?
Yeah. You know, a very long time ago in Sanskrit text, the Sushruta Samhita says that a person who's, I'm going to read this, not off the cuff, but I'm reading this because it's so very relevant to the connection and understanding where we can go with understanding our body. So the Sushruta Sanskrit text says, a person whose basic emotional and physical tendencies are in balance, whose digestive power is balanced, whose bodily tissues, elimination functions and activities are in balance, and whose mind, senses, and soul are filled with vitality, that person is said to be healthy. And I just find that to be such a fabulous, all-encompassing wording of how we all really strive to be. It's a pretty tall order to have all of those systems in check. And my goal in working with people is to give them empowerment in understanding their body and all of those systems. What keeps them happy? What keeps them functioning from truly head to toe and all between? And understanding that as physical therapists, we have a really unique opportunity. The body is very divided in Western medicine, And the pelvis in particular is subdivided with so many different specialists. You've got neurologists that might deal with the nerves to the area, vascular or interventional radiologists, orthopedists dealing with the bony structures, and then you've got gynecologists or obstetricians, or maybe combined. You've got colorectal surgeons, you've got gastroenterologists, you've got urologists, you've got urogynecologists. Sure, what else I might have
That
missed
was a long enough list. It's true.
Right? Mm-hmm. And as physical therapists, we have this wonderful opportunity to bridge that gap. And I find that in giving people hope, and again, that is understanding their health, understanding all of the connections. Everything is connected. There's no such thing as a separation of body and mind. We are completely connected head to toe through connective tissue and fascia, through our nervous system of spinal cord and peripheral nerve roots, through our vascular system, and through the function of our brain as kind of the conductor of that orchestra. So helping people understand all of the connections that may not only be myopically related to the one major symptom that they think is the most important in their life, because it's never just about the vagina. It's never just about the shoulder. It's never just about, your foot. So I really strive to make sure that people understand that first off, and then understanding that in knowing about all of those systems and understanding their anatomy, then they can find personal empowerment to actually use that information in a different way. To talk about the fact that I have been a semi-professional dancer, because it goes back to really where I started. I have always appreciated movement as the expression of what is going on in our whole self. Movement is as natural as breathing. It could be the flick of an eye in one direction, or a shrug of a shoulder, or how we carry ourselves. And so I studied dance and anthropology in my undergraduate degree. I was a double major in dance and anthropology, and people, my parents thought that was a little crazy, and what are you going to do with that? But my approach was that understanding that studying dance gave me the empowerment and the fluency of how movement might help me express myself, and studying anthropology in other cultures and how they move and live helped me understand all of the potentials of other people. And so when I then became a physical therapist, I think that I had a real bonus in understanding from a visual perspective and from a real understanding of even the way that person sat across from me and began to speak to me or walk into the room. I was able to begin to analyze what might be going on behind that.
I thank you. That was kind of all beautifully said, and I have so many things I want to talk about based on what you just shared. And I have to disagree with your parents. I think it's a perfect combination of study. Anthropology is the study of a history of a people. And what you do as a PT is not only learn what's going on right now, but kind of the history of the use of that person's body. Whether it be, they were a dancer, or they were someone who lifted heavy cement day in and day out, and how that impacted the movement of the body, the use of the body, the functionality of the body, and then putting it together. So I think it's a beautiful combination.
Yes, thank you.
And I also wanted you in the quote that you read, I love this concept of senses and soul being the duo leading to health. And it's just a kind of a beautiful synthesis, if you will, of kind of the psyche and spirit of our life experience and our movement. So thank you for sharing that. And I also really liked that this acronym HOPE. So often in the healing world, there's so much negativity. There's so much gloom and doom. There's so much kind of hyperbole about what you didn't do right. So thank you for giving particularly women who are coming to see you or who you're speaking with this sense of, wait a second, let's shift it. Can you speak a little bit more about that?
Yeah. And I get that information so very quickly by watching them move and understanding that, the soul and their senses, everyone has a backstory. Everybody comes to the moment with a history, with experiences, both whether they're perceived as good or not so good, and what might seem good to me may not seem good to you. And we all carry that lens in different ways. And so I'm able to see, even when a person is sitting in front of me, our bodies, there was a book, Our Bodies Keep the Score, right? And I'm sorry that I can't remember the author of that right now, but the author should be credited. The body does keep the score. We hold our history. And if a person is sitting in front of me with a carriage, the way that they carry themselves as being very closed, and they're slumped in their chair and they're kind of leaning back in the chair and their tail is curled between their legs, literally, like the frightened puppy or the angry cat, I'm able to use that information just from my observation to try to drive the story, because the person is going to tell me what's going on just in telling me their history. And if I'm able to help them feel comfortable enough to trust me to share their story, then I really can get so much more information to help unpack that. And I call it resetting or recalibrating where their brain and nervous system might be holding their perception of some of that history.
Yeah. So, as I prefaced, what I'd like to make sure we talk about is the mind and the body and their interplay. And a phrase that you use is understanding the body. And I use that a lot too, knowing the body, because I want my patients to know, what feels like in the head and then the body. What are the strategies that you use to help patients know their body, understand their body? Because I know for me, some people look at me like, huh? What are you talking about?
Yeah. Yeah. And so many people really have never learned about their body in the global sense, never mind the sexual sense. And I will say that Dr. Ruth just passed away.
I know. I just read that at 96.
96 years old.
Lots of good sex and talking about sex.
Right.
It's good for us.
That's right. That's right. But, what a pioneer in beginning to open the conversation about things that people were never really taught were okay to talk about.
That's right.
So that's certainly one area. But even in understanding the way that posture might influence something else up or down the chain, I do try to start with teaching patients about posture. We go through some movement, just sitting in the chair. How do you feel in your breath when you're sitting with this slumped, flexed posture and your legs are crossed right now and your shoulders are forward? And can you see that your neck is jutted forward a little bit? And can you feel how much space you have in your body when you're sitting like that? Now let's sit up really tall. What has changed there? Can you tell that your architecture is now in a different place? And can you feel the bones underneath your buttock as kind of the roots of your tree or as the pillars of your architecture? And can you see that everything now has stacked more efficiently on top of that? And we kind of start from there, because very often people lose their sense of proprioception, or that sense of where they are in space by definition, and need a little bit of guidance on what it feels like to move in different ways. And then I use a lot of visuals. I really do try to have three-dimensional models, skeleton models, models of the spine, models of the disc material between the spine, to understand how posture might affect all of those different parts. And especially when we're talking about the pelvis, that people really are just flabbergasted. They don't know where their parts are.
That's for sure.
And it's really helpful to have an actual three-dimensional model where I can say, here's your bladder, here's your uterus, here's the rectum. Imagine what would happen if your rectum was storing a lot of stool because you haven't had a bowel movement in a week, right? It's going to affect the neighborhood. And look here, can you see this is what's under the skin? Did you know that this is where your urethra was? Did you know you had 3 openings as a person born with a vulva, right? And so just that in itself helps people kind of understand. And being able to read the patient also. How much of that information are they ready for?
Yeah.
A lot of people are not even ready to see the pelvic model. Maybe I stay on one side of the pelvic model before going to the other. So helping that way. But but then translating it into movement.
I wish I had a lens looking at all the people who are listening to this show, because all I can say is that Jen and I, our producer in the room, we're both like shifting our pelvis, sitting up straight. I feel like I'm in the teacher's room. I'm like Alyssa's going to be looking at me with this wonderful critical eye. But also, as you just described, a way of looking at the body as a tree with roots, that visualization is so helpful because, again, we kind of move through our lives with an absence of awareness of how we are in space, how we are in our just sitting in a chair. So thank you for being so, visual in the way you describe that. I think that's so helpful because, that's we look at trees all the time, hopefully. And so, I can understand the concept of roots, this big trunk, branches. Maybe my body is a little bit like that. How do I stand erect? How do I move with the wind or with my running or whatever it is? So, that was very, very helpful. Thank you.
And just giving people permission to actually take a minute and actually assess and take a little bit of a scan of themselves, because I don't know that everybody's looking at a tree. Everybody's so busy.
That's right.
People have like 100 tabs open in their brain, and doing so many different things. Multitasking has become really toxic, and the expectations are just enormous. And we've gone from being, quadruped people or animals to being vertical. And now we're all getting back to sitting and trying to give people permission to move.
Yeah. I mean, an extension of that, of course, is that we're on our phones, we're on the computers, so our posture is not good as a result of these very universally used parts of our lives. Absolutely.
Yeah.
Can you expand a little bit? You mentioned about breath and posture. Can you speak about that, please?
Yeah. The way that we hold ourselves in our posture has a lot to do with what's going on in our brain and in our nervous system. And I feel that, our volume button of what we are experiencing around us is in the brain. And so many of us are in a state of being wound up. As our nervous system has two major branches. One side, we are running away from a tiger and we are in this kind of fight-flight mode, and we are just on the go and running away from whatever it is, whether it's a deadline that we're running toward or whether there's something that has been traumatic in our life that is keeping us running, versus the other side of the nervous system, which is the rest and digest and kind of the breath and soothing awareness side of us. And when we're constantly running, that part of our nervous system tends to be so quiet. And our breath is a reflection of where we are. If we are running from a tiger all the time, then our brain is essentially saying, okay, Alyssa doesn't have time for you right now. Take smaller breaths. She doesn't have time for a bowel movement right now, for sure. She doesn't have time to stop and stretch. She is sprinting. And what I tend to see, and it's always amazing to me because it really tends to be the rocket science in the room, is if we can reestablish an awareness of breath, even for, a moment or 15 seconds of one breath cycle, we can really, I'll use the word again, recalibrate the nervous system in a very optimizing way. When we breathe, our primary muscle of inspiration is the diaphragm. And the diaphragm sits like this big dome, big bulbous muscle underneath the rib cage, and it sits in the shape of a semi-closed umbrella. And when you take an inspiration breath, a breath into the body, what should be happening is that the diaphragm should open like the umbrella opening, move down into the abdomen, pushing all the abdominal contents aside, and your abdomen and your rib cage should expand. When you exhale, it should naturally and passively recoil back up to its original shape. When people are sitting in closed postures where they are inherently in a mode of protection. Something in their brain has said, I will keep you alive, I will protect you. And our bodies naturally go into this protective mode where our muscles tend to tense, our rib cage tends to depress downward, our pelvis tends to curl again into that position where the tail is tucked between the legs, and we go into this mode of perhaps in that sympathetic nervous system, that feeling of I'm going to curl up because then maybe the tiger won't see me, or maybe the tiger will think I'm dead and move away. But in that posture of protection and in that posture of nervous system fight back, you really can't breathe so well in that position. Mm-hmm. So the diaphragm is going to be restricted. It's not going to have as much room to move. And so when I ask people to do what I call, my standard homework assignment is what I call hourly inventory. And that essentially means every hour, give or take, whatever works out for your real life, trying to tune into yourself. See where you are in that moment. See if you can reestablish an open posture, and see if you can establish a, quote, deep breath. And in that moment, just looking around yourself in that very moment and see if you can establish to yourself that, in fact, you are safe. But when I'm describing that assignment to patients, 9.5 out of 10 times, I will watch the patient listen to me speaking and take a, quote, deep breath. And what I tend to observe from their state of initiating, from a flexed protected posture, because that's typically where people are when they're sitting in the office, at first at least, I see their chest elevate, their collarbones elevate, their shoulders elevate. I see all the little muscles of their neck, become pronounced. And I'm able to then demonstrate that to them. And I say, okay, I'm going to mirror you. I'm going to mirror what you just demonstrated to me. And tell me what you see. And now I'm going to demonstrate to you what I'd really love to be able to see in you. And I want you to first watch my neck and my upper chest and see what happens. And as I take my breath into my diaphragm and into my lower rib cage and into my abdomen, you don't see anything in my neck or my chest. And so now I'm not going to be shy. I'm going to show you now really my belly and what happens to my belly and what happens to my rib cage. And they can see that my belly can inflate and my ribs can inflate to rather large. And I have to give that permission. As women, especially, and a lot of men too, but as women, we are taught to suck it in, hold in our belly. The jeans should be a little tight. Now,
we did a show on corsets.
On corsets. I heard that show.
Yeah.
Yeah. And that, of course, used to be the way.
Yep.
If you didn't have a cinched waist, then we'll make it so.
Yeah.
And so a lot of women are now never giving themselves permission to actually let their belly inflate, to let their abdominal tissues have length. And that tends to drive enormous issues of pain, of bladder issues, of bowel issues, of sexual pain issues, headaches, TMJ disorders, neck pain, shoulder pain, wrist pain, everywhere pain.
Yeah. I always wonder whether it was a PT who coined, the knee bone's connected to the thigh bone, whoever wrote that song or was kind of brilliant.
Spot on, aren't they?
Yeah, really. Thank you. Yeah, I think that was just such a really nice way of helping all of us understand how even something that may seem simple, like breathing, is an automatic phenomenon if one is living, but the way in which we breathe can be a mirror as to what our body's doing, and in a way vice versa. And the idea that you watch someone breathe from the minute they walk in is just it's just kind of remarkable. I often say to my patients, we spend our days panting, and it's just exhausting. So since I'm a gynecologist, we have to go to the pelvis.
Please.
And also what you've pointed out is what so many people don't understand. They think the PT is for the broken arm and for the after a stroke. And you so beautifully, again, described how a PT is involved with, head to toe, movements of all sorts, and then pain phenomenon. So when I see a patient, or I should say, when I think about sending a patient to a PT, there are several different scenarios. And then there are many scenarios, but it's often about pelvic pain. It's about pain with sex, something called dyspareunia. It's about intra, postpartum, because pregnancy changes our pelvis so much. It's about incontinence of bowel and bladder. So there's a lot of reasons a gynecologist can be and should be sending you to a PT out there. So why don't we, I guess let's just start with, all PTs don't do pelvic work, right?
Correct.
Yeah.
Right.
That's more education that you got to do that work.
Yeah. My journey to becoming interested in pelvic floor therapy does not start from my graduate school experience. I literally never heard anything about the pelvic floor anatomy in my graduate school experience at Columbia. Mm-hmm. Now they are beginning to introduce it more, but I hadn't heard about it at all until my first continuing ed course that I took related to pregnancy and postpartum and indications for physical therapy for that clientele. And my instructor for that course, who I will name, was Hollis Herman, and has been an incredible influence on my journey, but really an incredible pioneer in educating physical therapists and other therapists as well. Occupational therapists are now getting into the field as well, really trying to educate finally and talk about what's happening in the pelvis. So it's continuing education.
Yeah.
Physical therapists can specialize in lots of different areas, neurological or, wound care or orthopedic or et cetera. But the pelvis sits in between all of these other structures. So to be a pelvic rehab specialist, one really does have to understand everything that's happening above, including the neurological and the orthopedic, and all the way down to what's happening in the mechanics of the foot. We are specializing in any issues related to bladder, bowel, or sexual dysfunctions. But really, truly, it is a whole body, whole person approach because there is a bio, psycho, social, neuro, musculo, skeletal, visceral, emotional, vascular, musculoskeletal system that we are, really having to understand. There are a number of things that go on through our transitions as we age, through puberty or pregnancy or post-pregnancy, whether that ends in a delivery or not, and the transitions into perimenopause and menopause, which we are now finally getting very strongly on the soapbox to help women understand what they're going through, which can start, 10 to 15 years before they actually stop bleeding.
Yeah, exactly.
So really, really important to be educating there.
So let's just talk about a patient who's come to see me and say, Amy, I can't have sex. I used to be able to have sex. I used to have penetrative sex and I enjoyed it, but now it doesn't feel good. In fact, I can't even kind of put my finger inside my vagina, or I'm still menstruating and tampons, they just don't feel good anymore. And I send that woman to see you. What happens? What happens?
Yeah. So, that kind of patient is describing a secondary vulvodynia. So it's dyspareunia, which is defined as pain with penetration, which specifically sexual penetration in that definition. But I always like to expand it and ask the question of, well, how do you feel with a tampon insertion, or how do you feel with the GYN speculum examination?
Right. Anything going inside.
Anything going inside. And, a lot of things can come into play. That person used to experience penetration, fine. So what has changed? And we have to think of that, again, from a head-to-toe lens. Has there been any significant trauma that all of a sudden has presented itself? We all carry in our nervous system the imprint of any experiences that we may have gone through, generational or ancestral, or something that we've observed, or something that we have actually personally experienced, physically or sexually, or some other kind of either little t trauma or big T trauma. And so we hold that in different ways. So is this person now, for some reason, holding some kind of protective mechanism throughout their nervous system? Again, posturally, are they holding in a way that is at a subconscious level where their muscles of their pelvic floor and abdomen and probably other areas of their body are holding tension that they're not even aware of? You know, our pelvis is a place inherently that is private, that carries shame in a lot of people. And so, you know, a lot of people will keep their legs closed and hold their legs together and hold those postures that are, you know, below the waist is a no-fly zone. So what's going on that person might be doing in their body that is protecting them from something? But the other thing to consider is, what else could it be? You know, maybe that person fell skiing 2 years ago or even longer ago and, you know, fell on their tailbone or fell on their hip, or, you know, has been really loving pickleball and started playing after not doing any major activity for a number of years, and now is, you know, running side to side and changing directions and running up and running back and, you know, jumping and doing all these things. And is there something orthopedically that then is influencing the pelvic floor? You know, the pelvic floor doesn't just sit in a vacuum. Again, everything is connected. And in fact, one of our major hip muscles connects directly to the pelvic floor. So someone with a hip issue, is the pelvic floor driving it, or is the hip then driving a pelvic floor issue? And what else might be going on?
So I think what you're pointing out so well is that if someone out there listening is thinking, I don't, you know, sex doesn't feel good anymore, penetrative sex doesn't feel good anymore, and you're struggling to figure it out, a PT may have a real significant impact on healing, because they can look at it again from the whole body perspective, not just the gynecological one, which is certainly a part of the treatment or cohort that can help you understand what's going on. But again, you may not think, oh yeah, that hip injury is in fact got something to do with the way sex feels. A lot of people wouldn't put the two together.
Yeah.
So don't assume they're separate. They, in fact, may be very much related.
Yeah. And in our history taking, we can kind of start to, you know, unpack all those pieces. And then ultimately, with the patient's consent, we also will look and feel and see what's going on, because there also could be a hormonal component, or there could be a dermatological component, or something that might relate to their underlying autoimmune issue. And so that's also why it's great to have an interdisciplinary team that would include a gynecologist.
I think we should all see PTs like every 5 years, in the absence of injury, so to speak, that we see PTs. Because again, some of what you're pointing out is just the way we are in our everyday life.
Yeah.
And so much of the activity we do is not, you know, kinesthetically all that healthy. You know, chopping over and over and over again, typing over and over and over again, phone and computer use, or the work. I know the work that I do has been extremely hard on my neck. Operating, pelvic exams, these things have really demanded a lot of me that I never thought about. No one ever talked about it. Only now are there opportunities when you go to national meetings. Are they talking about how do you hold your body when you're a surgeon? I mean, can you imagine that? After decades and decades of us standing in ORs and not ever asking, how do we make sure we can continue to do this throughout our lives?
Yeah, definitely. And you know, I have to say that I also put it out there to patients that some of your behaviors may not ultimately change, but if you can understand how what you do or what your patterns of behavior are may contribute to then how you're holding and what your symptoms are, that in itself gives them hope.
Yeah. Empowerment.
And
Absolutely.
empowerment. Because if you can attach it to a reason, if you all of a sudden have diarrhea and you know that the day before you ate a whole lot of stuff that you never would have eaten before, like a bowl of fettuccine Alfredo, then you feel a little bit better. At least you can point to something that says, oh, it was that.
Right. We like causes and effects.
Yes.
It helps us feel less overwhelmed by the unknowns and all the ways our bodies can and minds can, if you will, act out. Yeah. I wonder, has there ever been a discussion about like all pregnant persons should have PT? Do you think there's a role in that?
Absolutely.
Yeah.
Absolutely. And in other countries, it happens.
Oh, really?
So in other countries, it's standard procedure that you get a physical therapy examination during pregnancy, before delivery. After delivery, it's standard procedure that you get physical therapy. Here, it's just not. And no matter how many grand rounds I would do at the hospital, whoever would show up would be, wow, great, but still, it's not an automatic referral. And for so many reasons. I mean, wouldn't it be great if we all could have our bone scans a little earlier in life versus the, age 65 when chances are your bones have already had a problem? Why can't we be proactive and more preventive in our approach? So, it's certainly on the bucket list to continue to educate the bigger groups who may or may not include people who are already in pain or something. So try to prevent some of this stuff. But certainly pregnancy is just such an enormous process for our bodies. I just don't think that anybody has appreciated the physiological changes that go on in the body. I mean, that's a gross overstatement. Of course, many people do recognize the hugeness of that process, but it really should be standard procedure that we're trying to help women navigate that transition.
Yeah, just because it's a so-called natural process, which, it is, the way in which we live our lives is not so natural anymore, one. And two, thankfully, we have information now about how to care for the body, particularly the pelvis, vis-a-vis pregnancy and delivery. So why not use it? So again, to the audience out there, if you have an opportunity to ask your obstetrician whether you can see a physical therapist and build that into your prenatal care and postnatal care, I would recommend it. Obviously, the big obstacle in the room is insurance and payment, and this is all, it can be terribly prohibitive, but it's worth a question or an inquiry, right?
Yeah, absolutely. And especially because we do know that there is a large percentage of women who will go through birth and have some kind of perineal injury that may end up with urinary incontinence or fecal incontinence. So, trying to prevent that and do some proactive care so that delivery can be optimized and recovery can be optimized, and also so that the patient is just as informed as possible.
That's right.
Is really so important.
How many times have you heard, because I've certainly heard it many times, if I had only been told beforehand that this was a possibility, I may have said, at hour 2 of pushing, enough is enough. I don't want to go the 4 hours that somebody told me I should try for example.
Yeah. Informed consent.
Yeah, exactly.
Yeah.
Exactly.
Yeah.
I would love for you to help me understand and explain this phenomenon of hypertonus and hypotonus. So sometimes the pelvis can be so in a state of contracture, hypertone, and then sometimes the pelvis can be in a really relaxed stage, and both places or both states can lead to problems.
Yeah.
Can you help me and perhaps everyone else out there understand it?
Yeah. All of our muscles in our body need to have length in order to have strength.
Length in order to have strength.
I
like that.
I can't squeeze my hand closed with great strength unless I can first open it. I use the analogies of, a baseball player has to be able to reach back in order to propel their arm forward to pitch a ball. Or a basketball player has to be able to bend their knees down low in order to jump up high and, throw for the basket. Or, the analogy of a pogo stick. We've all jumped on a pogo stick.
I like that.
If that spring can't expand, then we're not going to be able to get that jump, right? So we have to be able to store energy throughout our body and in our muscles in order to actually create power. And sometimes in the pelvic floor muscles, particularly, we'll focus there, but it can happen anywhere in our body, like our jaw muscles or in our shoulder muscles or in our gut, in our abdominal muscles or glutes. We will, at a subconscious level, again, be holding tension. Again, posturally, sitting in a slumped position is going to almost inherently begin to shorten the muscles. The area between the sit bones, those two bones that we sit on, those hard bones, when we sit into a slump position, those bones relatively come closer together. So the muscles between those bones are going to be in a little bit more of a shortened state.
Now, is shortened the same as
tight?
Tight, contracted?
No, not necessarily.
Yeah. Okay.
So, when we talk about tone, we are really talking about a shortening but spasming of a muscle where it can even be velocity dependent of a contraction or a contracture of those muscles that is demonstrated on EM, versus a short muscle is where the fibers of the muscle have come closer together and kind of stay that way. And so there are people who are carrying more tension and where there will be a more increased resistance in muscles, right? So we're kind of getting away from using tone because we're not measuring tone.
Got it.
But where we're talking and using language more of restriction or resistance. And versus having pliability and extensibility in muscle. So again, with my hand, using that as an example, if I can open my hand really, really wide, there's full length and extensibility of the tissues around my hand. And then if I close my hand really tight, those muscles are drawing in and contracting. If I hold that muscle, that hand closed all the time, or perhaps I've had a neurological injury which has caused a fisting of my hand over time, I'm going to lose the extensibility of all of those tissues, and it's going to be harder for me to open my hand. So the muscle has become shortened, the connective tissue has become shortened, and there's become a scarring, if you will, or fibrosis of the tissues around it. So when we think about the pelvic floor, we are looking at what is the baseline state of tissue texture. Is there a stiffness to the texture of the muscle, or is there a flaccidity of the muscle? There are people who have had pelvic floor injury. So perhaps in a childbirth, there is a stretch injury that naturally occurs, and sometimes over repeated injury like that, the tissues and the nerves can become more flaccid. The nerve signals can become slower and weaker, and so it doesn't drive as the same kind of muscle contraction. And so the patient who has truly a flaccid muscle tone and texture will typically have more weakness in their muscle strength because they're starting from a hand that's beyond open. It's hyper open, right? It's hyper flexible versus someone who is able to contract the muscles but has lost a sense of how to extend the muscle. So over time, if they're holding tension because they're protectively guarding, for instance, sometimes, again, through the proprioception and awareness of where we are in space, it's no longer really in the repertoire to know how to extend those muscles. We've all, for instance, had our shoulders up to our ears, and it's only until someone comes over and puts their hand on my shoulder and says, Alyssa, relax, your shoulders are so high up. But I wouldn't necessarily know that they were there. And very often we see that in the pelvic floor. There are other circumstances in people who have generalized joint hypermobility. So, for instance, a condition called Ehlers-Danlos, in the subtype of hypermobility, where there's a little more joint mobility than expected or than necessary. And this is the double jointed person and the person who can, really go into Cirque du Soleil and bend in all kinds of positions. What we often see in people like that who, seem to have a lot of flexibility and hypermobility in their joints, in their pelvic floor, very often we see compensatory tension, where the muscles of the hips and the pelvic floor are really trying to hold on for dear life to offer as much stability as possible, where the ligaments are not. So we're really looking for that,
So one can have these combinations.
Absolutely.
Depending upon, what muscle group you're looking at.
Absolutely.
Yeah,
a
that's
stiff
very
person doesn't necessarily, like a stiff jointed person doesn't always have a stiff, tight pelvic floor. And conversely, someone who's particularly flexible and hypermobile in their connective tissue doesn't always have a lax, weak pelvic floor.
Prolapse.
Or a prolapse.
Right.
So a prolapse can happen for a number of reasons. Was it pushed or did it fall is the big question. But sometimes a prolapse can come with a lot of tension and tightness in the muscles because, again, even at a subconscious level, they're trying to hold on for dear life.
Right. And prolapse is a relaxation in the pelvis. We see it in our exams, the gynecological exam, where there's a relaxation on the anterior wall or posterior wall of the vagina, where bladder is kind of pushing up against the anterior wall or bowel against the posterior wall, or the uterus is coming down. So some people will come in and say, I've got this bulge coming out of between my legs. And that can be literally their uterus, their cervix and uterus coming down out of the vagina. It could be that extensive.
Yeah. And I'll just say, after that description of feeling like something falling out or bulging or that I'm sitting on something, unless someone looks, it's not always a prolapse.
Right.
Because sometimes people who have a lot of pelvic muscle tension and restriction will report the same kind of feeling, like I feel like I'm sitting on a golf ball.
Yeah.
And they think that means that they have a prolapse. And so they think that, shouldn't I do Kegels? Didn't somebody say that, you should do Kegels if you want to get stronger? And yet, meanwhile, maybe that's not the problem at all. Maybe they're sitting on what feels like a golf ball, but it's actually a knot in the muscles and holding so much tension. And so
Kegels is the worst thing they
further
might do.
Contracting might not help them. Now, that's not to say I'll kind of just take that as an invite to just also say that I am not someone who likes to also say never do Kegels, because I think that there's really a place in learning what a contraction of the pelvic floor muscles is. A Kegel, for anybody who's listening who doesn't know, was named after Dr. Kegel, who decided at some point, did some research and found that by contracting the muscles around the urinary sphincter can affect urinary incontinence. But again, if people are in any state where they've lost a sense of where they are and what their muscles are doing, I do find that teaching them what a contraction is can sometimes be the best way to then teach them how to reverse that and let go and lengthen.
So how do you teach them? Teach us.
Well, similar to, I go through this process, like what I mentioned, how our shoulders might be up to our ears if we're not, quote unquote relaxed. That word is triggering for a lot of people. But if our shoulders are up to our ears and we don't even recognize that, sometimes I'll say, okay, well, shrug your shoulders even more. And I'll bet that when you go out of that position, you come down to a better place, right? So if your shoulders were halfway up to your ears, you shrug up even more, and then you let go. Now all of a sudden your shoulders are lower. So in your pelvic floor, same kind of thing. Can you contract your pelvic floor muscles?
How do people know? What's really the simplest way they might know if they're not, to designate what's the pelvic floor versus the abdomen versus the rectum per se?
So the pelvic floor sits between the pubic bone and the tailbone and the two sit bones, those two side bones that we sit on in our buttocks, and almost like a diamond shape. And piercing those muscles are your urinary sphincter, your urethra, your vagina, and your anus. And so those muscles should be able to both close the openings and lift them gently up into the body. That's a Kegel contraction, versus also be able to relax downward and open. Now, those sensations can be felt as if you were stopping your stream of urine, which now and then, when you're sitting on the toilet, it's okay to test yourself now and then. We don't encourage it all the time so that you don't kind of screw up the timing of your bladder, but it's not a terrible place to test yourself and see if you can close your sphincter. You're not going to cause any major infection or anything like that. So it is a place where you can objectively see, can you slow down or stop your stream of urine? Also, the sensation of perhaps squeezing a toy or a male partner, that sensation of closing your vagina around something, and the sensation of holding in your gas. So those are kind of the cues that one might give. You could actually look in a mirror or even place a finger, if you're comfortable, inside your vagina and try to squeeze it gently. Can you do that? And so those are sensations. And then, of course, we really do like to check, because research shows that when people are told, just do this, where they're given a pamphlet that says, just follow these instructions and do it, very often they're not doing it correctly. And they may be compensating, or they may be bulging instead of contracting, or they may be contracting instead of relaxing. And all of that can then affect urinary function, bowel function, sexual function. So we like to check. And we have the, good privilege and opportunity and experience and knowledge to be able to do that and really make sure that our patients know what they're doing. But I will, if someone is having any tension, right, I will say, squeeze, do a Kegel, so that then when you relax, you can reverse that Kegel and feel the lengthening, and feel the dropping, and feel the opening. Sometimes I'll use the visual of a jacket with a zipper. And you're going to close the jacket together, you're going to zip it up, then you're going to unzip the jacket completely and let the jacket fall apart. So as many visuals as possible. And pelvic PTs tend to have a rather large repertoire of visuals.
They're very poetic.
And images, so that we can, what's going to work, and what might work for one might not work for another.
So we're moving towards our close, and those listening do not have the advantage I have of looking over at Alyssa, this beautiful woman who's wearing this great T-shirt that says, "Find your perfect balance." And what I love about your tagline, Alyssa, is that the double entendre. It's like we're always talking about, for particularly us women, like finding our balance with work and home and family and cooking and all the balls that we tend to have in the air. And I actually, at this point in my life, don't talk about balance. I talk about just finding some wonderful, comfortable movement back and forth like a seesaw, that I'm never going to be in balance. I'm just always going to be on one side or the other, but that's okay. I'm just going to continue to have that, if you will, that dance. But you're also talking about another kind of balance. So I want to just bring that into our conversation before we close. So what does balance mean to you in terms of finding your perfect balance?
Yeah, well, there certainly is a dual entendre in there, especially for my practice, where I am trying to help people find their own balance in life and in the confidence that they can have in their body in order to be able to address all things that are necessary, whether it's, as you say, all the balls in the air, but also understanding their body, but also recognizing that our true balance, our balance to not be able to fall, is also incredibly relevant and important as we are going through our transitions as aging women, and also recognizing that it's even related to the pelvic floor. The same nerves that innervate the muscles of your pelvic floor also innervate the little muscles in your feet. And we use 3 different systems to maintain our balance. One is our somatosensory system, and that relates to what we feel in our feet and how our muscles and our nerves help us know where we are. The other is our vision. We really like to have our eyes open and the room to be lit so that we know where we are. And then the third is in our vestibular system, which is housed in our inner ears. And as women, as we age and as our levels of estrogen decline, we have estrogen receptors everywhere in our body, including in our inner ears. And so the ability for us to recruit the cues from our vestibular system also declines as we age. And so I always integrate balance training into any of my pelvic recovery or rehab or knowledge and understanding. So it truly is a head to toe and all between, maintaining balance in every which way that I try to target.
Great. So I like to close Gynocurious conversations with just an honoring of pleasure in our lives. And as I point out to the audience frequently, is I'm not just talking about sexual pleasure, because not everyone's having sex, and moreover, intimacy is as pleasurable as sex can be. But as a dancer, I would imagine there have been moments where there's been great pleasure. Can you share with us perhaps one setting or one experience as a dancer where you had immense joy?
So many as a dancer on stage, performing, the feeling of stimulating an audience to feel something. And I think that has always been where I find great pleasure in the movement that I practice. And it doesn't always have to have an audience, but I certainly feel great pleasure in inspiring people through my movement. There was actually even someone when I was working at the hospital, and I won the Employee of the Month award 1 month because someone had written a letter to the bigwigs at the hospital, because the way that I walked and my posture as I walked down the hall inspired her.
Oh,
and that she left our sessions holding me in her mind and on her shoulder as inspiration. And it was based on how I moved. And I feel that is really such a privilege to be able to speak to people through movement and to inspire people to understand how their movement also can inspire others. And I'll go back to that posture thing again. If I can help people give themselves permission to feel more open and to feel more allowed to enjoy their body, to enjoy the space around them, to know their body before they have any partner or any colleague or, friend come into that body, they're going to have much more confidence and, know thyself first. So, movement has just inspired really my whole life since I'm 3, rolling around under a piano, where the teacher says, okay, now be spaghetti and now be a meatball, and learning the difference of, am I closed up tight like a meatball, or now I'm stretched out like a long skinny spaghetti?
Oh, that's
so
great,
and really that all of those little memories have carried me through.
Yeah. I am inspired to say that what I feel emanating from you is just an open heart. And with an open heart, it's coming through your expansiveness physically, the capacity to literally open the heart by sitting up straight and kind of revealing that part of your body that's such a vulnerable place, right? And then clearly all the work that you do with your patients that sounds like just a kind of beautiful integration of your knowledge of the body, but also your capacity to embrace them in all their different forms and challenges. Yeah. Alyssa, thank you so much for joining me today.
Thank you so much for having me.
It's been just a great pleasure. I also want to thank Maddie Rosenberg and Jen Hammoud, my co-producers, and to the Epicurean again for hosting Radio Free Rhinecliff. Until next week, the next episode, please stay well and remember to listen to your instincts and intuitions. They are the greatest of teachers, not to be ignored.